Hi, good morning, everyone. Thank you for that introduction. So my name is Rachel. I'm a third year medical student. And before I start, I just really want to thank everyone who is part of this project. So my PI is Dr. Michael Kim here, as well as Dr. David Thompson from South Africa and the Alberta Critical Care Strategic Clinical Network. And big thanks to my co-authors, Lena Demetric and Jack Underschultz. So this study was about intensive care units in South Africa, looking at them pre-pandemic and during the pandemic, and use qualitative methodology. So as a quick overview, we'll go through background, methods, results, and then talk about next steps and some conclusions from this project. As a bit of a background, we all have heard a lot about ICUs lately, especially in the news. And what they do is provide life-supporting treatment to critically ill patients. But as we can all recognize, not all ICUs worldwide have the same resources or the same capacities. So for instance, in South Africa, which is a lower middle income country, there's 5.5 to 9 per 100,000 ICU beds, versus in a high income country like Canada or the USA, where there's greater than 15 ICU beds per 100,000 of the population. So as you can see, there's a big discrepancy in the availability of beds, but what's even more different is the level of training that healthcare providers get from the physicians or the residents and even nursing staff in ICUs, treatments that are available. So things like ECMO or other dialysis, things like that are not universally available. It's something we take for granted here, as well as different protocols for triaging and vastly different equipment, things like oxygen concentrators versus high flow machines, the use of medications, those are all different. And while already operating at low capacities prior to the pandemic, any disparities felt by ICUs were extremely exacerbated due to strains caused by surge capacity when huge influxes of COVID-19 patients started flooding ICUs worldwide. So the objectives of this project were to determine different protocols, practices, as well as the capacities in South African ICUs, both before and during the COVID-19 pandemic. But really the purpose of this project was to examine what lessons could be learned from a lower resource country in adapting to high extreme resource and staffing constraints, and how do you apply those to a high resource setting. So this was a mixed method qualitative study using sequential steps of inquiry to inform subsequent steps. So we started with a focused literature review, trying to understand what the context of critical care in South Africa has been and currently is. Next, we did healthcare provider interviews to really appreciate and understand the lived experiences and changes in ICU functioning to frontline healthcare workers before and during the pandemic. And then finally, we used a healthcare provider survey to consolidate and better validate findings from the interviews with a wider range of healthcare providers. So for the purpose of this project, I'll focus mainly on the interviews. So the setting and participants, I don't know how many of you are familiar with South Africa or Cape Town, but Groote Schuur Hospital is their major tertiary public teaching hospital. And before the pandemic, there were 25 ICU beds with 5 units. So that's cardiac, neuro, surgical, medical, and I think they have a pediatric ICU. And then Victoria Hospital is a smaller district level hospital that's still in Cape Town that has 3 ICU beds with 2 units being a surgical and a medical. And people who participated were medical officers. So we don't really have an equivalent there, but they're more general practitioners who haven't completed specialized training, whereas consultants have completed extra training in specific like anesthesia, surgery, internal medicine. And then registrars, there were 2 general surgery registrars, and they're the equivalent of our residents. So the first part of the interviews kind of looked at scoping what the pre-pandemic resources were. And overall, both at Victoria Hospital and Groote Schuur, they mentioned that there were great multidisciplinary teams with nurses, consultants, registrars, physical therapy, dietitians, lots of staff available with 2-to-1 or 4-to-3 nurses to patients. So not exactly 1-to-1, but pretty close. And overall felt that their equipment was, although outdated, was able to care for the patients that they had. So for instance, at Victoria Hospital, there was no high flow machines, but there was a ventilator. And one thing is they don't have norepinephrine they don't have epinephrine in South Africa. They only have norepinephrine. So that was a change in inotropes available. And as well, there was a good mix between pretty much equal surgical and medical ICU beds. So even though we might think of it as low, having different resources or less resources, overall, the ICUs felt that they were functioning quite well and weren't feeling constraints. However, when the pandemic came, there was a lot of panic and lots of preparation went into both hospitals in order to better prepare. So this is a quote from the consultant at Victoria Hospital explaining how they saw 6 weeks before their first patient was to come in, they really de-escalated all their services. They canceled all elective surgeries. Anyone who wasn't critically ill was moved either to periphery hospitals or else moved to long-term care centers. And they converted some of their wards into high care beds. So before they didn't have cardiac monitoring on those beds, they got cardiac monitors in, and they managed to get 10 new high flow oxygen machines into Victoria Hospital to have what they called high care beds, as well as their 3 ICU beds. And similarly at Crucis Sker Hospital, going from 25 ICU beds, they converted a bunch of the ward beds into COVID beds and scaled up to 60 ICU beds, mainly by repurposing staff and taking a lot of surgeons and anesthetists away from elective surgeries and repurposing that way. And so when asked about what some lessons learned during the pandemic, there was a big emphasis on the fact that lots of the time they're told that there's no way to upscale services. It's impossible in order to provide more care or better care. But when there was a political imperative and agenda that was moved towards increasing care, then it all of a sudden became possible. They were able to cope extraordinarily well, despite being scared of having low resources, increasing number of patients at already their capacity was already full. But what they noticed is that they coped well. They had pretty healthy outcomes and were not as overburdened as they thought they were going to be. And things like repurposing of staff, refurbishing of equipment that had been donated from high-income countries to be used in those settings, and then as well as having strict protocols for who was coming into ICU and who was not, instead of just having consultants decide subjectively who was appropriate. So in conclusion, the places with low resources and tighter capacities found innovative ways to increase capacity and care for acute patients during the pandemic. However, this was at the expense of surgical and non-emergent patient care due to cancellations of elective procedures and appointments. So patients who were needing surgery presented much later and with much more comorbidities and longer hospital stays. So next steps is we're also completing interviews and surveys in Kenya, and we would like to compare those results and assess differences between the two countries with differing income levels on the same continent. And then finally is what lessons can we transfer to high income settings to help us prepare for times when we might be more resource constrained. Thank you.